In this section, I'm going to just run through a typical dictation, trying to give some idea of our flow into dictation, the points we try and make. In this particular case, this was a 54-year-old woman who had a questionable area of architectural distortion noted on her mammogram. Before evaluating the MRI, I always make a point to thoroughly evaluate the mammogram and, if there are available, ultrasound study, as well as any pertinent history. Having done that, we then proceed to the case itself. In our case, we always perform an unenhanced and enhanced exam of the breast bilaterally, with rare exception. So in this case, I would enter this exam as a bilateral, unenhanced and enhanced breast MRI with coding for that. In addition, we do use CAD post-processing, and so there would be a code 0159T post-processing code or CAD post-processing. You must be sure, however, that you actually perform each of the steps required for that and indicate that in your dictation. If you refer to the CPT coding portion of our lecture series, you will see details on what codes are available for breast MRI, as well as what needs to be within the dictation to justify those codings. Upon opening the study, the first thing that I evaluate are the 1-minute subtraction MIPS. I can see immediately that this is a good study. My contrast bolus is good, the vascular and cardiac enhancement is good. I can also see that there's very minimal background parenchymal enhancement in this case. There is one small focus of enhancement in the right breast that we will need to evaluate, but I can see that pretty much this is not going to be a complicated case. I will generally image this screen save for the portfolio that my physicians that refer to me have become very accustomed to looking for, and then I occasionally will add on the color parametric mapping and film that, but in this case it really doesn't add anything. Next, I'll go to my craniocaudal MIP projections, and I'll film those as well to give both a lateral and craniocaudal projection view for my referring physicians. They come to always expect these views as the initial two views on the portfolio saved for the patient. Again, I can see this is really a very straightforward case. These are the ones that can make your day pretty easy to look at. Next, I'll go to my thin 1.5 centimeter MIPS, and I'll get an initial survey of the breast starting medially at the internal mammary arteries. Again, I filmed this to let my referring physicians know where they are oriented in the breast, and I just step out getting representative images of the breast bilaterally. In this case, we did have one focus of enhancement in the right breast, which we can see here, so I'll be sure to grab an image that includes that and step out to the lateral breast. Then I'll bring a pull down that gets more into the raw data as opposed to MIP images. At this point, I now have my high-resolution T1 and STIR images displayed side by side. This is where I begin my dictations. After initial introduction, where I will state the equipment I use, we go straight to this. My dictation will go something like this. Bilateral high-resolution imaging was performed of the breast bilaterally utilizing a dedicated breast coil and a 1.5 Tesla magnet. Initial unenhanced imaging of the breast bilaterally demonstrates a moderate amount of fibroglandular tissue symmetrically distributed. I can evaluate this by panning through the STIR and T1 images. I would then go on to delineate cysts or asymmetric breast edema. There are no dominant cysts within either breast, period. There is no asymmetric parenchymal or skin edema, period. No lymphadenopathy is identified, period. Again, you can see on these high-resolution images, you're able to evaluate the axillary lymph nodes, looking for normal reniform configuration with smooth cortex. So at this point, I've gotten an initial unenhanced overview of the breast. There's no lymphadenopathy, there's no cysts, there's no dominant mass apparent, at least on these initial unenhanced imaging, and I've made sure to evaluate into the chest wall for any unexpected findings. At this point in my dictation, I insert a standard technique dictation. This is very important because in order to appropriately bill for various codes, whether it's an unenhanced or enhanced breast MRI or post-processing, you have to appropriately document that. The easiest way we found to do that was to make a standard dictation that we can insert with each of our exams, and we know it covers the procedures that we performed. Please note in an earlier section of this teaching seminar, there is a segment on CPT coding and what's required in your dictations to justify your various procedures. So at this point, I would say please insert my standard parallel imaging technique standard dictation. Then I would proceed as follows. New paragraph. Dynamic bilateral high-resolution imaging of the breast bilaterally demonstrates no significant asymmetric regional or focal enhancement, period. As I'm doing this, I'm able to step slice by slice through the images simultaneously of the right and left breasts, looking for enhancement, evaluating the subtraction images as well as the raw data. Now I know I have one area of enhancement in the right breast, which my initial impression on the MIP was that it's not going to be particularly significant. As we navigate through, you see again there's just nothing of significance enhancing until we get to this small lesion right here. We can enlarge that, try and get a look at it. Now it does demonstrate some high threshold enhancement kinetics and some degree of washout, but we also see that it's got a very smooth contour to it, and there's some suggestion of a reniform shape. Cross-referencing of this smoothly enhancing, somewhat reniform shaped focus in the right breast with the T1 acquisition demonstrates again a reniform configuration or horseshoe shaped nodule with, on this T1 sequence, a fatty hilum. This is just a normal intramammary lymph node. I would then proceed with my dictation. New paragraph impression colon. There are no signal or enhancement characteristics within either breast to suggest malignancy, period. Incidental note is made of a intramammary lymph node in the 9 o'clock B zone of the right breast. Period end, Bio-Rad's code 2.